Hello, everyone. Thank you for joining the Center for Learning Health System Sciences for our monthly impact seminar. Before we get started, I'd like to cover a few expectations. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button next to the Raise Hand option in the Zoom menu. The public slide deck will also be made available on our website under the Education tab. I will post the link in the chat along with a short questionnaire asking for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. In particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder for upcoming LHS events, the next seminar will be on December 3rd with Dr. Aaron Hove. And with that, I will turn it over to Dr. Mary Butler to introduce our guests.
Good afternoon, and I am very, very excited to introduce everyone here on our panel that will be speaking today. These are highly valued colleagues of mine as well, and I know that you're going to enjoy hearing from them. Dr. Meera Viswanathan is a health services researcher and a systematic review methodologist and a senior fellow at RTI International and directs RTI International University of Northern Carolina, Chapel Hill Evidence-Based Practice Center. She's also a research fellow and adjunct faculty at UNC Chapel Hill and recently led a portfolio of work on centering racial health equity in systematic reviews as part of the U.S. Cochrane. Dr. Jennifer Lin is a practicing general internist in primary care and, again, a systematic review methodologist. She's a director of the Kaiser Permanente Evidence-Based Practice Center and serves as the PI on contracts that support the U.S. Preventive Services Task Force. She recently led the development of a health equity framework for the task force and also worked on methods consultation for other guideline groups such as American College of Physicians, Kaiser Permanente National Guidelines, and World Health Organization. And Dr. Anjali Jain is a pediatrician and health services research who also serves as the medical officer for the Agency of Healthcare Research and Quality and the evidence-based practice program there. During her 4 years at AHRQ, Dr. Jain has led projects on a variety of topics, including the impact of healthcare algorithms on racial and ethnic disparities in health and healthcare, and strategies to address racial disparities in healthcare, and others focused on youth mental health, women's health, climate change, and other. And in addition to her work on evidence synthesis, including guideline development, Dr. Jain has been recognized for the impact of her published research on a range of other health topics. So these three valued colleagues and doctors also recently led the Scientific Planning Committee for a summit on addressing racial health equity in systematic reviews and healthcare guidelines. And that was co-sponsored by AHRQ and the Robert Wood Johnson Foundation. So with that, we look forward to hearing their presentation entitled Addressing Racial Health Equity in Evidence-Based Healthcare Decision-Making. Thank you.
So I'll take it from here and I'll share slides on my screen. If you give me a second. So thank you so much for inviting us to talk about racial health equity in evidence-based decision-making. Just a note that when we talk about racial health equity, we're also including ethnic health equity under that phrase. And three of us, as Mary said, three of us will be discussing this topic. So I will start by addressing the what and the why, supported by an example. Jennifer will address the how, and Anjali will address what next. And this presentation was based on work that was partially funded by the Agency for Healthcare Research and Quality. It was also partly funded by the Robert Wood Johnson Foundation. None of the presenters have any affiliations or financial involvement that conflicts with the material presented in this presented here. I wanted to acknowledge the group of this is the immediate working group that put a lot of contributions into the summit and the findings from the summit, but also wanted to acknowledge the many unnamed people who participated in the summit. All right, moving on to my specific talk about racial health equity, constructs and implications. I'm going to start with an image from the Robert Wood Johnson Foundation that describes the differences between equality and equity. I recognize that many of you listening would be very familiar with these constructs, but I'm just going to go over them to level set. I think we've all seen some version of this kind of image. A very popular one is, different sized children peering over a fence, and how you achieve equity in that scenario is by offering different sized children blocks of different sizes to make sure that they can all peer over the fence equally. And in this particular image, you see where everybody's goal is the same. They all have locomotion in mind. Equality is giving everyone a bike, even though some people can't use it. Equity means, so it takes the idea a little bit further. You modify it somewhat to give everybody the opportunity to move forward. Now, a revised version of this distinction between equity and equality acknowledges that not everyone is the same. Not everyone requires the same tool. It may not be needed or right for everyone. So in the image on the left-hand side, you can see that the third person doesn't get a bike. They get a different kind of tool. And so equity, in effect, is making sure that everybody gets what they need. And that needs to happen in the context of understanding the barriers, circumstances, and conditions for each person. So moving on to the definition of health equity, a pretty standard definition offered by the Centers for Medicare and Medicaid, CMS, says that health equity is the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of their circumstances, which might include race, ethnicity, disability, sexual orientation, and so on. So in that context, health inequity is the presence of avoidable, unfair, or unjust differences in health outcomes. When you apply this to race or ethnicity, racial health equity is the absence. So racial and ethnic health equity is the absence of unfair, avoidable, or remediable differences in health and well-being among people belonging to different races and ethnic groups. So once you start thinking about inequity and you add race and ethnicity to that mix, you have to ask why. Why are you focusing on racial health equity? And we all know that there are vast differences in health outcomes by race or ethnicity, and these are persistent. But we also know that race is a social rather than a biological construct. And we know that efforts to model away these differences by replacing race or ethnicity with various socioeconomic proxies have not managed to dispel differences by race, which then leads you back to the fact that social and structural factors, which include race, cause racial health disparities, and these can cause biological differences in health outcomes. In effect, race leads to racism, which can have biological consequences. So addressing racial health equity requires addressing social and structural factors, including racism. So in addressing racial health equity, it's important to also acknowledge that the motivations to address racial health equity can vary. You might do it because it's the right thing to do. You might also do it because it gets you to the right place. So organizations or systems like health systems may be concerned about ensuring that resources are appropriately distributed and that you have the best possible health outcomes, optimal health outcomes at the least possible cost. And that's an instrumental reason to address racial health equity, which is also acceptable. So I'm going to now move on to an example of what happens when you attempt to address racial health equity and how that can impact systematic reviews and guidelines. So the specific example I'm going to offer is a systematic review that we conducted to support the U.S. Preventive Services Task Force statement on interventions to prevent child maltreatment. And I'll refer to the U.S. Preventive Services Task Force from now on as USPSTF. So this review was to look at interventions to prevent child maltreatment. And as these things go, it was a pretty standard analytic framework and questions. So on the left-hand side, you see that we were looking at children without signs or symptoms of abuse or neglect. And we asked, do interventions to prevent child maltreatment improve outcomes? And you can see the outcomes listed on the right-hand side: reduced exposure to abuse or neglect, improved health, behavioral, developmental, emotional, mental well-being. And then we also asked about harms, acknowledging that those harms could have included the destabilizing effects of CPS reports and removal of the child from the home. And, this could have included job losses or family dissolution. So we looked at these set of factors, and we did this review twice for the USPSTF. So an almost identical team did this in 2018 and then again in 2024. The first time we addressed this topic, we didn't have an equity focus and we didn't address drivers of inequity. But then by 2020, the USPSTF was reflecting deeply on their role in calling out racism, and the 2024 review took on as a pilot an equity focus. So both reviews led to the USPSTF making statements of insufficient evidence. So neither review changed the potential offerings to address child maltreatment because the evidence was insufficient. In both instances, the task force said the balance of benefits and harms cannot be determined. But the 2024 review did lead to the USPSTF making statements about social and structural determinants, and they called for a new framework. So I'm now going to show you step by step. I also want to acknowledge that it took effort and resources to make this change. It took time and labor hours, but also a commitment to addressing equity, which is that is a broad implication for addressing racial health equity more generally. So now I'm going to break down for you piece by piece what it actually means to have made this change. We started in a completely different place in 2024. Our motivations were different. We acknowledged race as a social construct. You can see that we did those things in 2024. We did not in 2018. And this did influence our methods. So although both reviews talked about racial disparities in the introduction, and both talked about potential subgroup differences in benefits and harms, what we did first, we both talked about potential subgroup differences. What we did for the first time in 2024 is actually summarize what those were and delve into reasons as to why racial disparities exist. And this came from acknowledging race as a social construct. So if we do that, we acknowledge race as a social construct, we have to ask why race matters. And in both reviews, we had identified the presence or absence of potentially, we had talked about the differences between, in the absence or presence of differences in effectiveness by race. But in 2024, for the first time, we identified racial bias as a difference, as a driver of those disparities for the first time. So what eventually changed as a result? Not the recommendations, but for the first time, we actually did change the recommendations for new research, although the recommendations for preventive interventions themselves did not change. So it did alter our perspective on the evidence completely. So as I said, the evidence was mostly graded as insufficient. There wasn't enough evidence to make a change. But because of our much more race-aware approach, we were able to see the role of racism in this evidentiary chain. So we saw bias in who got selected for the interventions. So in many trials, eligibility was framed in a way to oversample Black women. And this resulted in differences in who got selected for the interventions. And there was also a bias in how outcomes were measured, both in trials and more generally. In some trials, some interventions arms actually had a higher rate of CPS reports than in the control arms because of observer bias. And then more generally, in practice, there's empirical evidence that Black children are disproportionately reported to CPS. And in fact, for some services, for example, skeletal surveys after a head injury, where you would expect everyone to get treatment, white children were actually getting less treatment than desired. So bias was hurting everyone. So this focus on equity helped the team understand flaws in the original framework because it wasn't acknowledging the central role of racism in the system. So that's an example of what happens when you explicitly address racism in health services, and how this shows you an example of what happens to the resulting systematic review and recommendation. So I am now going to turn it over to Jennifer Lynn, and I will move slides for you, Jennifer.
Thank you, Meera. So hi, everybody. I'm Jennifer. First off, I just want to thank you all for the invitation to come and share some of our work with you and spend the hour with you all. So I'm going to share some findings from a project that we undertook to support the Racial Health Equity Summit that Mary had mentioned at the top of the seminar. Next slide. So for this project, we started with the questions, so we were focused on systematic reviewers and guideline groups. So we started with the question, how can reviewers provide actionable information, or how can guideline groups provide actionable recommendations to mitigate racial health inequities? And to do this, we needed to understand, first, what are the questions that we need to be asking? And then second, how do we best answer these questions? So although, again, we focused with systematic reviews and clinical practice guidelines, I do believe that the principles that I'm going to share with you today are generally applicable to evidence-based decision-making in general. So for this project, we summarized the guidance to date addressing racial health equity and evidence synthesis and evidence-based healthcare decision-making, and provided examples summarized sort of in three main content areas. So first, promoting representation and relevant expertise. The second is identifying and developing racial health equity focused topics and questions. And the third was applying specific methods and processes to answer these focused questions. Next slide. So for this work, we had a fairly large work group with members from the Evidence-Based Practice Centers, a Scientific Resource Center, as well as AHRQ, who had expertise in both reviews, guideline development, portfolio management, interest holder, aka stakeholder and public engagement, as well as health equity expertise. And to identify the existing guidance and exemplars, we leveraged the prior evidence scans that we did for the U.S. Cochrane and U.S. Preventive Service Task Force work that was mentioned before, and we supplemented these with additional targeted literature searches. We also did audits of the ECRI Guidelines Trust database and the AHRQ Evidence-Based Practice Center program portfolio to identify exemplars. But in the interest of time for this brief presentation, I'm just going to focus on summarizing the guidance that we found and not discuss the examples. But we hope to have a paper out hopefully early next year that will have the full representation of examples that we found. So I'm going to walk through the highlights of existing guidance that we found with respect to representation. Oops, apologies, next slide. Identifying topics and questions, and then methods and processes to answer these questions. So starting with ensuring a wider perspective. So regarding having subject matter expertise on review teams and guideline groups, this really refers to people who have lived experience as members from different racial and ethnic groups, as well as persons having health equity expertise or training. And this can also mean involving, when relevant, non-clinical subject matter expertise from other disciplines. So having interest holder representation and perspective means engaging or partnering with patients and public from affected groups with the intention of engagement early in the process, and also addressing barriers limiting participation. So for example, providing compensation, addressing power dynamics. And it also means engaging patients and public on not just the valuation of outcomes, which is typically done, but other aspects, including the implementation of interventions. Next slide. So moving on to the next category, regarding identifying and selecting topics, guidance really suggests using a health equity criterion to prioritize topics with the potential of addressing racial health equity, recognizing that oftentimes there are many different topics that we feel that we need to address from an evidence-based decision-making process, but we simply don't have the time and resources to do everything. So we use criteria to help us select and prioritize, and being explicit about having health equity as a criterion is important. So to address racial health equity, there's also an opportunity to identify and develop topics that are specific to addressing racial health equity, in addition to building in racial health equity into reviews or guidelines that are sort of broadly applicable to all populations. So for example, this could be something like the use of community health workers to mitigate the disparities in the receipt of, to increase the receipt of preventive care services. In either scenario, whether developing topics that are focused on addressing racial health equity or building in racial health equity to topics that are sort of broadly applicable to all populations, it is really important to develop questions that are designed to understand what are the upstream drivers and what are the mechanisms leading to racial health inequity, including the relationship of race and ethnicity to other social determinants or social risk factors. And these can typically be done or facilitated using logic models or other conceptual models. Guidance also suggests that the importance of developing questions to understand implementation factors affecting racial health disparities, and this may entail asking questions beyond feasibility, accessibility, cost, and resources. Next slide, please. So moving on to methods and processes to answer equity-focused questions. When thinking about what evidence is important to look at, guidance really suggests considering a wider set of evidence for both questions on the intervention effectiveness, as well as other questions addressing upstream barriers in implementation. When addressing risk prediction or prognosis questions, guidance suggests assessing for both algorithmic bias and fairness in multivariate risk prediction or risk prediction models, whether race or ethnicity is included or not. As a variable. Algorithmic bias is can be assessed by sort of reviewers during a critical appraisal phase, and fairness is something that the guideline groups or the decision makers should consider to mitigate any risk of implementation of an imperfect or biased risk prediction model. Next slide, please. So for both reviewers and guidelines, it's really critical to understand the effects of across different racial and ethnic populations, which entails understanding the applicability of what the included evidence is to the population that we see or that we treat. And this can be, and typically we do this by extrapolating what we see in included studies, the relative effects that we observe in studies to underrepresented populations that aren't in included studies, unless, of course, there's a compelling reason not to, or a compelling reason to question the applicability. When we do suspect there might be differences in relative effects, this should primarily be derived from credible subgroup analyses, rather than sort of indirect comparisons across included studies. So for decision-making, I think we can all agree it's critical to understand what are the differences in the absolute benefits and harms across different populations. And this can be done even when evidence is limited to more diverse populations. And this can basically be estimated by applying the relative effects observed in the included studies to the baseline risk of specific populations using various different methods. Next slide, please. So in formulating decisions or recommendations, it's critical to integrate what we know from a broader set of questions beyond just asking effectiveness and harms. These questions, at minimum, should include those that address the mechanisms leading to racial health inequities, as well as implementation considerations. And it's also prudent to consider providing guidance on strategies to improve the receipt of recommended services, especially when there is a known differential receipt of services, and that differential provision of care or receipt of services is driving racial health inequities. Next slide. So finally, I'm just going to end with the importance of addressing what is not known or what is still needed. So there's an opportunity to both identify evidence gaps in future research with a specific racial health equity lens. And I'll also advocate that there's an opportunity for evidence for guideline groups, as well as any evidence-based decision maker or health systems, to articulate clinical practice gaps as well as policy gaps that need attention to address racial health inequity. And next slide. Thank you. And I'll turn it over to Anjali.
Thank you. Thank you, Jennifer and Meera, for introducing the topic and discussing it so well. So I'm going to build on what's already been discussed here and talk a little bit about a summit that we convened as a group. Next slide. Okay, so in June of this year, a group of us did convene a summit to address racial health equity. It was sponsored by AHRQ and the Robert Wood Johnson Foundation with some support from the U.S. Cochrane Group. And the purpose of the summit was to understand the current state of the science and to create sustainable networks and connections between individuals and organizations that are really dedicated to working on this topic and very interested in working on this topic. So our hope is that the summit was really just the beginning, and that this work will continue in collaboration and us being able to learn from and draw upon the work of others. The attendees for the summit were evidence synthesis and guideline developers and researchers, health equity researchers, community members, advocates, government agencies, and members of the public as well. Next slide. Okay, so in terms of the summit itself, a lot of the thinking that has gone into this topic was in convening the summit, during the summit, and then afterwards. But the elements of the summit were that we first conducted a pre-meeting survey to get a sense of what was being done already and the interest on the part of the attendees. We had presentations that included the audit of the AHRQE Guidelines Trust, which is a clearinghouse or a warehouse of current guidelines, the portfolio at AHRQ, at my agency, as was mentioned, particularly looking at the racial health equity related efforts and its presence in being addressed in all of our reports and guidelines that result. We also summarized some of the existing guidance for how to incorporate racial health equity into systematic reviews and guidelines. And we had presentations of ongoing efforts among the attendees, as well as highlighting some novel or innovative approaches to address equity within the evidence synthesis space. Even though we did have a number of presentations, we really wanted the focus of the meeting to be a working meeting and to have a lot of online and in-person small group discussions, as well as asynchronous chats that to highlight the themes and priorities for the group as a whole. So some of those, the transcripts from the meeting and the themes that resulted were both developed and verified by reviewers. And we are writing, as Jennifer mentioned, we're writing that up in a series of papers that are aimed for publication. Next slide. Okay. So as Jennifer already mentioned, the importance of representation, I thought I'd share a little bit, just a little bit of articulation of some of the themes that she's already discussed and give you a few quotes that kind of get at some of the discussion and the poignancy of it. So this quote, "I think these reviews represent a good opportunity for patients to help because I don't think a lot of them are done with diverse teams of people. So I think we need more education, awareness, and training to help include more patients in those being the reviews and guidelines. So it was certainly articulated that there was huge benefits to having adequate representation, but currently there's a real lack of representation, and that includes both on systematic review teams and guideline panels, but also every step along the way, including the asking of the appropriate questions. We need input from those with lived experience with the condition, but also that belong to disadvantaged racial and ethnic groups. There was a lot of discussion as well on some facilitators of meaningful engagement with people who have lived experience. And again, the importance of stressing that very early on in the process. Next slide. Okay, there was a lot of emphasis on making sure we are asking the right equity-focused questions that would actually get at disparities and address them. So discussions around how to prioritize, identify, and develop equity-focused questions at the onset of a review and ultimately a guideline, but also recognizing that the questions really need to go beyond the traditional effectiveness questions, because it is not just about the effectiveness of an intervention. It's about the implementation of the intervention. It's about access issues before, during, and after the intervention itself, as well as are there ways for our reviews and guidance to really incorporate some of the barriers and facilitators of care, including the incorporation of some of the upstream factors such as racism and root causes of the illness and its consequences. We also stressed the importance in the meeting of outcomes specifically related to health equity, with some input about what those were. But one of the things that came up a lot was looking at both relative and absolute effects, which can get sort of lost in risk ratios and are harder to understand that the impact on smaller groups within the studies. It was also discussed that the use of logic models that explicitly incorporate equity and to really detail the relationships between some of the racial health equity factors and the way the interventions work or don't, and the related upstream and downstream factors, including implementation. Next slide. Okay, there was a lot of discussion. Okay, what do we do? What are the approaches to effectively including and addressing racial health equity into the questions, into the reviews, and into how the guidance is interpreted? So one thing that came up quite a lot was the idea of including more inclusive sources of evidence. But this was met with notes of caution as well, because we don't want to allow lower standards of evidence for marginalized groups. So there needs to be particular caution in interpreting some of those conclusions. But some of what was discussed was the inclusion of qualitative studies, of mixed methods studies to really understand better the contextual factors, as well as studies that really look at implementation specifically for groups that experience disparities, so racial health minorities in this case. There were a lot of expressed concerns around the use of subgroup analysis as being highly suboptimal as a way to approach racial health equity. Now, this comes up a lot because, unfortunately, subgroup analysis is the prime way that racial minorities are addressed in studies. I assume most of you know what that is, but I'll just go ahead and explain it just in case, which is the idea that instead of just looking at the effects and the effect size in the entirety of the study population, the subgroups, or let's say Blacks or Hispanic groups, for example, would be looked at separately, and the the intervention and its impact would be looked specifically in that group. Unfortunately, this is suboptimal for a number of reasons. One is that the study size is typically too small to allow definitive conclusions, and the study was not powered as such. And so it can actually lead to false conclusions that an intervention is ineffective or doesn't have harms in that particular group, just because the strength of evidence is too low to make that clear. Next slide. All right, there was a lot of discussion on understanding applicability, or the extent to which the reviews themselves, the studies that they're based on, and the guidance that results, does it really apply to the real world? And specifically, does it apply to the groups that are going to be affected by these guidelines? So some of the applicability factors that arose in the discussion were things such as context, meaning the context for the implementation of the guidance, but also the context of the study in which it was actually conducted, the logic model upon which the study was based. Did it incorporate racial health equity? Was that a consideration in how the intervention was designed and carried out? The causal pathways between the various factors and the outcomes, and are there unmeasured factors that are affecting the effectiveness of the intervention? Representation in the primary studies and how this may differ. And unfortunately, the primary studies are often based on a more ideal study population. And so typically it doesn't include racial minorities to the same extent, and may or may not in the end be applicable to those groups. Currently, the idea is that because unless there's a good reason to not include a certain group in terms of the guidance, they should be included, because inaction could be a problem too. But I think you can all understand how we're still extrapolating a lot of information without clear evidence of the effectiveness of interventions or their safety. So the impact of applicability on guideline recommendations, as was just mentioned, how the study context can impact the applicability, and the inability to even assess the extent to which applicability is reasonable. Next slide. Okay, so some of the challenges and opportunities for guidelines that are attempt to be more equity focused and equity addressing. One we've already discussed, considering different evidentiary thresholds, the challenges in developing some equity focused guidance, especially in the absence of adequate literature and studies that included minorities. The consideration that guidelines can and should try to address some of the upstream drivers of inequities in recommendations, as well as the downstream drivers in terms of how they're implemented. That there is, of course, potential for some unintended consequences of the recommendations and how they address disadvantaged groups. And then the challenge also of communicating guideline recommendations to diverse audiences, including patients generally, whether or not they belong to a racial minority. Next slide. Around reporting, there is a huge need for consistent language and reporting, as well as using plain language in how the results are disseminated. So using inclusive language means including different racial groups, genders, all the different intersectional factors, but also having a consistent definition about how some of the how the studies are conducted, a similar definition, or at least a transparent definition, how race was defined, for example. Standardized reporting can increase transparency, but improving the reporting is not just enough. We also have to improve the interventions themselves and their outcomes. Next slide. All right, and we want to measure success, of course. I will read this quote. The term impact is used so much these days, but seldom properly measured or reported. A monitoring and evaluation framework would be integral for collecting the proper data that can be used as measure of impact. There's a lot of efforts to measure success, but currently a lot of the data is really looking at process measures or intermediate outcomes rather than the ability to look at true health outcomes, especially for racial and ethnic minorities. Next slide. Okay, thank you. So our emails are here, including Christine Chang, who's the director of our EPC program. And you can see the QR codes, and those are available to get more details about some of the work you've heard about today. Thank you very much.
Thank you all for your presentation. We have about 9 minutes remaining for the Q&A. If you have questions or comments, please use the raise your hand feature. We also welcome you to type your questions into the Zoom Q&A.
If there aren't a lot of questions, we would love to hear about some of the efforts in the audience to address racial health equity in your own work.
All right, we have one question that says, do you have a specific search strategy recommendations or screening recommendations?
I can speak a little bit about some of the work we've done around search strategies. We did actually do a methods project within our division, including some of the people who have been in the work group, to look at different search strategies, particularly look specifically for terms associated with racial and ethnic minorities that might not always be seen. And I don't know if this is good news or not, but it seems like the addition of extra terms did not really enhance the ability to find those studies. And so what I think that means is that we're finding the studies that are out there anyway, but there really aren't enough. I don't know if someone else wants to answer the second part of that question. Screening, I wasn't quite sure I understood. The question was about aspects of screening. Screening, what kind of screening?
Hi, I asked that question. Can you all hear me?
Yeah, now we can, Bronwyn. Thank you.
Okay, thanks. So when screening abstract after we've done our search and we have our data set, any terms you suggest that have been high yield for identifying studies that may provide some insight into health inequities?
Unfortunately, I don't know.
Yeah,
that they're sort
I
of
think
like
much
it.
like
Okay.
much like the
Anjali.
search hedges work, I don't think it came down to additional terms. Every search strategy for every review is designed specifically for that review. And so I don't think that it's terminology related. Jen, were you about to say something as well? Please do.
No, I was just going to say, I wish there was sort of an easy answer to that. I think in terms of, screening through literature, I think it really has to do with some questions are much easier to screen through included evidence, but than others, but for a lot of these questions that are sort of what we're calling equity focused questions, they aren't as sometimes straightforward as what is the effectiveness? And so, I don't think that this is necessarily, so I think it's really going to vary on the question that you're asking. And some
varies
are
by topic.
arguably,
Yeah.
a little bit more complex to go through, which I think brings up one of the elephants in the room, which is, I think to do this well, it requires resources. And to be honest, if you're adding questions around racial health equity and you're really trying to understand what the drivers are, and the mechanisms are, as well as sort of like the downstream considerations, it does require extra resources to do. There are no sort of like quick and easy or quick and dirty kind of solutions, but I'm a strong believer in sort of incremental change. And so even though that we acknowledge that some of what we're asking may be more resource intensive, it's not that you have to do sort of everything or ask every single question, but even just starting early in the process, asking one or two questions, beyond sort of intervention effectiveness or harms, it is really important in sort of moving the needle.
And there was discussion at the summit about whether or not equity should be automatically included in every review. And I think the answers to that were a little bit inconsistent, especially because of the resource issue. But, I think at least thinking about it in the background of the review and the justification, and looking specifically at those topics where there are disparities, looking a little bit more carefully, perhaps at the grade literature, which we sometimes do. Sometimes we include contextual questions, which don't require as much effort as the review questions, but still significant. And one thing I've read about, we haven't started to incorporate as much in our studies, in our reviews yet, is that looking specifically for community-based studies, which are often, messier. They're not as easily translated into rigorous RCTs. But that's an idea I've at least, heard about as one way to get more real-world evidence into the reviews.
I did want to add a little something to one of the questions that's already been answered by Jen about interest holder participation and trying to include patients who are intended beneficiaries. This is, I don't want us to, underrepresent how much effort it takes. It requires a really reinvestment of resources in specifically that activity. Because we really have to work hard against tokenism, expecting too much, expecting not providing people with adequate resources to help provide the input that we're seeking from them, but also to recognize that lived experience is in fact what we're seeking. And so finding the right balance of appropriate training. One of the ideas we've toyed with is potentially creating a standing group of interest holders, but then the question always remains, how relevant would their life experience be to a specific topic? So I think that although there's huge amounts of work to be done for all of the topics, this is one that's probably had the least amount of work put into it. So it is something that we'll be continuing to work on, I hope, in the future. There was one other question that came up about Jen's typing an answer. So I don't know if you wanted to continue typing. I'll speak up, Jen.
No, you should answer. I'm just trying to get to as many before the time ends, but no, you should answer.
Okay. I see your question about funders inclined to support the extra resources. I think some of it is also on demonstrating impact. If we can show that addressing racial health equity has discernible outputs, then I think people will be more willing. It's one of these chicken and egg situations. We have to do it sometimes potentially within existing resources in order to show that it makes a difference. There's probably smaller pockets of money available than we'd like, but there are ways to extend existing resources to try and do things that are relatively low effort. And in fact, we will be working up some of those in order for us to put out a list of, sort of low-hanging fruit. And then there was, yeah. So I'm going to stop.
I can add something to that. Yeah, I'll add something to that. So in our various audits, we also found that a significant portion of reviews already include some aspect of racial health equity in the scope of the review. And there's certainly been a handful that are real exemplars that have been really focused on racial health equity. One of the ones I worked on, which is the relationship between algorithms in healthcare and disparities, was entirely focused on that. And, that was funded internally, but there was a huge amount of interest and a lot of work already being done that we were able to include as like an expert panel and key informants. But then afterwards, we also had a meeting particularly organized around bias within algorithms. And that was, a pretty big meeting. And what came out of that was a sort of consensus around including industry and like a private-public group of guiding principles for how to address and mitigate bias within healthcare algorithms. And so there are these kind of ongoing efforts. And so every little bit helps, and they all kind of, there's a lot of enthusiasm, a lot of passion for really getting this right, both because of the sort of ethical reasons to do so, but I think also a recognition that improving healthcare for the most marginalized populations actually improves healthcare for all. And, I think most of us can agree that healthcare is not fixed. There's a lot of issues with it. And so, really making it a more universal system that's effective for everybody.
I know we're out of time, but I just wanted to say if GIN North America is going to help assemble a group of people who are interested in working on this topic, so let us know if you want to be added to that list.
Yeah, afterwards, I will share the slides to our website that has everyone's email so people can reach out to you guys. Well, thank you again to our speakers for taking the time to give this talk, and thank you all for attending. Again, in closing, please join us for our next seminar on December 3rd at noon Central Time. This concludes our presentation. See everyone next time.